Hi, this is Professor Cassidy, and I'm here to go over intubation and mechanical ventilation. Okay, mechanical ventilation is just the process of moving oxygen or air into and out of the lungs by a mechanical ventilator. It is not curative, it is just to support patients while they're unable to breathe by themselves. And the hope is that they come off the ventilator, but some patients do have to bridge to long-term mechanical ventilation use. Indications for mechanical ventilation include apnea, if they're not breathing, inability to protect the airway, like we saw with burn patients. If they come in with burns around their mouth or neck, we know that's going to swell up. So we will intubate them right away and put in an artificial airway. Acute respiratory failure, severe hypoxia, or also respiratory muscle fatigue. If that increased work of breathing is going on for a while, they're become so exhausted and their muscles become too exhausted to initiate that breathing process anymore. So they would need help with mechanical ventilation. There may be ethical decisions around using or not using mechanical ventilation at the end of life. And some patients here in Massachusetts have the AMOLST form. It goes under a different name in other states, but I think every state has similar options for patients to say whether or not they want to have CPR or be intubated. And also healthcare proxy, this is where it really comes into play with these really hard medical decisions. If you have somebody that you've already spoken with about what kind of medical care you want, it's easier for healthcare providers to give you the care that you would have wanted. Okay, types of mechanical ventilation. So there is negative pressure and positive pressure. Negative pressure, you can see on the left here, this is an old like iron lung. And that kind of like, when you think about the negative pressure, we have negative pressure rooms, right? For COVID or tuberculosis, and that is pulling air out of the space in the room. So there's less air in the space and creates negative pressure so that any air pulls into it. The same is true with this, but it's doing it by pulling like down on your diaphragm or out on your thoracic, so making the space bigger so there's less air and that rushes air into your lungs. I've never seen these. I'm not sure where we use them now, but I think they're still in use somewhere. What I'm more familiar with is the positive pressure, and that is us the machine actually pushing air into your lungs. And you can see the top one, this is positive pressure with a BiPAP. And the bottom one, this is positive pressure with a patient who does have an airway and intubation tube. Okay, so PEEP is positive and expiratory pressure, and I think you may all be familiar with this term at this point, and it's just the pressure that is applied to the airway during exhalation, just at the end of exhalation. They're preventing the alveoli from collapsing and getting stuck together. So it increases lung volume and improves oxygenation. CPAP uses continuous pressure and BiPAP uses higher pressure in inspiration and lower pressure during expiration. And here you can see the CPAP machine and then the BiPAP machine, which is the bilevel. So CPAP is used for people with obstructive sleep apnea, administered non-invasively with the mask, and it can increase the work of breathing because it's that constant level of pressure on inspiration and expiration. It's to keep your airway open while you're sleeping, but you do have to breathe against it while you're exhaling. Whereas BiPAP delivers higher pressure while you're inhaling to get it in there, but a lower pressure during exhalation to allow more gas exchange and more like carbon dioxide removal. So invasive mechanical ventilation, this is when you need the artificial airway. So the other ones were non-invasive. Now invasive is when we're going to put an airway in. And those are reasons for that are if there's an airway obstruction, apnea, high risk for aspiration, ineffective clearance of secretions, or respiratory distress. Artificial airways from mechanical ventilations, we place the tube into the trachea, bypassing the upper airway and the laryngeal structures, and it creates that artificial airway. with the ET tube, the endotracheal tube, and that can go by the mouth or the nose. And then also there could be a stoma created in your neck for a trach. And you can see right here, this is going in past the epiglottis and right into the trachea. And this is if it's going in by nasal. If you had mouth trauma or some reason you couldn't use your mouth, they would put it in through the nose. And then longer term use, they would create a tracheal stoma in your through your neck to the trachea to continue that mechanical ventilation. And this is what it looks like when it's in your trachea. This is the deflated as it's entered, or when you're taking it out, you deflate it. And then this is inflated, and you can see that it completely goes right against the trachea. So no secretions from your stomach can, I'm sorry, nothing from no air from your lungs can come up, and no secretions that would have come up from your stomach or from your mouth are able to get down into your lungs. Okay, so nursing care. It's important to maintain the tube patency. So we do use suction while they're intubated, and it's all internal. But it used to be done routinely. We don't do this anymore because it harms the patient lungs. That the suction tube is actually going down below the ET tube, so it does get to the tissue. So you don't want to do it more than you have to, because you can really cause harm. And you also want to try to manage secretions without the use of suction too. So adequate hydration, mobilize and turn the patient, and then antibiotics is needed for pneumonia. Oops, I'm not sure what's going on here. Go. All right, and this is what the system looks like. So this, if you follow my mouse, this is the suctioning tube right here, and this is where you would push the button to control. So you would insert this down. When you push this in, it goes down. It's all internal into their trachea, and you would pre-oxygenate them, give a lot of oxygen first, hyperoxygenate them, then push this down, and then push the button and suction on your way out. So another thing that's really important for patients who have an artificial airway placed is to do mouth care, because it's they're obviously not able to do it themselves, and bacteria can really grow in there, causing pressure sores from having all that bacteria in your mouth and the pressure of the tube, and ventilatory pneumonia. So this is the system that you'll see if you guys have been up to the ICU. I'm sure you've seen these, and they get care every 2 hours. So there's one with a toothbrush, and that's like to brush their teeth, and I think that's once or twice a day. And then the rest have swabs, and you're swabbing out their mouths. And this is with chlorhexidine, and this is to get the bacteria out of there. There's also little tubes of moisturizer that you're putting moisturizer in their mouth and on their lips, and you're repositioning that ET tube on their lip so that they're not getting to try to prevent getting a pressure ulcer. So there are some modes of mechanical ventilation. So there's quite a few different settings. I don't want to get too far into it, and I'm not going to go over any numbers at all in this video. I just want you to have an understanding. There's a couple different ways to support somebody in their breathing, and you can do that with volume ventilation or pressure ventilation. So volume is I'm setting the amount of tidal volume. That's the the liters. Like if you have liters of fluid, this is the liters of air that we're going to put into your lungs, and that is a set amount. So with every inspiration, we're going to put this much volume into your lungs, and then it's consistent with every breath. The pressure level might change, but the amount of volume of air that you're getting stays the same. Now, pressure ventilation, there is a predetermined pressure, and it delivers as much volume up until a pressure is met within your lungs, and then it stops. So you'll have the same amount of pressure, put into your lungs every time, but the volume might vary depending on, lung compliance or if you're coughing at the moment or anything like that. So the volume might change, but the pressure will be the same. And those are the two. There's different settings within these modes, but I don't want you to worry too much about those. I just want you to understand the two differences. And there's a lot of multiple different types of ventilator settings, and I don't expect you to know any of this, but I just wanted to show you what a couple different screens look like. And you can see, like, down here, if you can follow my mouse, there is the volume control. This is what the ventilator is set at. And then up here is what the patient is doing. And then over here, we've got the pressure control set over here. And then this is what the patient is doing. If you're working in an ICU or any place that is using mechanical ventilation, you will learn all about them. Okay, so the settings are in either one, they'll have the respiratory rate. So how many breaths per minute are we going to give you? These are just the main ones. Other ones are the volume, which we just talked about. The FiO2, so that's the percent of oxygen that we're going to give you. Romer is 21, and we can give up to 100%. The positive and expiratory pressure, that's how much pressure we're going to keep. The inspiratory to expiratory ratio, and the high pressure limit, which is called PIP. So alarms, and I think there's a couple questions. I think NCLEX has alarm questions on there, and there's probably one in our exam, so I thought I could go over them. These are there's different ones, but these are the most important ones. The high pressure, low pressure, and low tidal volume. So high pressure is there's something blocking the air from getting through. So there's something blocking the tube, like a kink, the tube is kinked or laying under the patient, or there's a mucus plug or secretions, or if the patient is biting on the tube, or there could be a blocked portion of the airway, like they're coughing, or if there's a big pneumothorax, that could cause a high pressure alarm. Now, low pressure is just the opposite. There's loss of pressure. So there is loss of air. So a disconnected tube or a loose tube or an air leak around the cuff, although that says cough, sorry about that. Or if the patient bites through the tube. Now, if they're biting on the tube, and you're going to get that high pressure, but if they break through, now there's low pressure because the air is being released. Also, accidental extubation. And low tidal volume is that the machine's not able to deliver the full tidal volume because of the peak inspiratory pressure has been reached. So if something happens that there is a lot of pressure in the lungs, and I'm supposed to be giving this much volume, but I'm not able to give it because that there has to be a pressure stop, because you wouldn't want the machine to just keep pushing against. It would blow through your alveoli and really cause tissue damage. So those are the three alarms that are important to some. Please have an understanding of those. And there is a problem with alarm fatigue, with the alarms going off all the time. So you should never turn off the alarms. You could pause them. There's like a 2-minute pause button, and then it comes back on automatically. But when you go in the room, you can pause it if it's just, dinging too much while you're moving the patient and you know that there's going to be some alarms going off. Okay, very briefly, just so you hear it, I want you to know what ECMO is. This is an alternative form of pulmonary support. So it is, dialysis takes some blood out and dialyzes it and then puts it back in. This does the same thing. It takes the blood out, gives oxygen, takes the CO2 out, and puts it back into your body. So it's just a way of doing gas exchange, and that's called ECMO. Okay, so nursing management. So monitoring oxygenation. So they'll do, anybody who is on a ventilator will have ABGs done frequently, and you'll monitor the PaO2. They'll also be on continuous SpO2, and there's probably internal hemodynamic monitoring as well. You can monitor for signs of hypoxemia, change in mental status, increased confusion if they're intubated. I'm not sure that you would notice that, but dusky skin, dysrhythmias, anything like that would cause them to have low oxygen in their blood, oxygenation. Okay, and you also want to monitor for ventilation, and that's the air moving in and out, right? And this we would monitor with the CO2. with the ABGs. And also this picture right here is an end tidal CO2. So that would be attached to the ET tube. Also their respiratory rate and rhythm and the use of accessory muscles. So this is some people who are on a ventilator. They are not doing any breathing, but a lot of people are doing some breathing. So you can see that, and if they're having increased work, that could be a problem with ventilation. Okay, so nutritional therapy is really important for these patients. The positive pressure ventilation and the hypermetabolism, both of those are burning way more calories than they would in their normal state. So they need more nutrition. Enteral nutrition is the preferred method. If it's not possible, they can do TPN or PPN until they can get the TPN. You really want to consult with a dietitian within 1 to 2 days to get this nutrition started. It's so important. Without it, they're going to have decreased O2 transport. They're going to have increased risk for pressure injuries. Any injuries that they get, there's going to be delayed healing. There's going to be delayed healing at all of whatever the underlying problem is, increased risk of infection, exercise intolerance, and delayed recovery. So nutrition is a huge need for these patients. Okay, also fostering comfort and communication with the patient and with the family. Now, you can imagine that, I mean, the patient will be sedated, but not necessarily unconscious completely. Is very anxious to have a tube down your throat, to be afraid, not know what's going on. So you definitely want to try to find ways to communicate with this patient. You can use a communication board, a paper and pen. Some people can text. If they're really anxious, they'll probably need more sedation. If they're in pain, analgesics and respiratory therapy. I'm sorry, relaxation therapy. Maybe some nice music or something. I mean, they can still hear and feel, so you want to still be developing that therapeutic relationship. Um, the emotional stress is, yeah, it's very anxiety producing. Um, So you want to encourage hope, build trust and relationships, and involve the patient's family and the caregivers as well in the decision making. And just remember that even though the patient is sedated, or even if they have paralytics on board, they're still going to be able to hear you. Right, here we go. So they might have to use a paralyzing agent. Some people who are really kind of fighting against the vent, they say it like they're breathing in opposition to what the vent is, but not able to produce enough oxygenation um, to support life. So they might need a paralyzing agent. So that is really important. If you can imagine being paralyzed and not being able to, you're not able to speak because you have a tube down your throat, but you can still hear everything. And if your eyes are open, you can see what's going on. So it's really important that they be sedated, because that is very traumatic to not be able to move and see what's going on. Okay, I'm going to go over some complications with positive pressure ventilation. So that pressure actually is transmitted to the structures of the thorax. So it compresses and it makes it decreases preload, which means you have decreased cardiac output. And PEEP increases the effect. So you have to watch out for these patients. They're going to have decreased venous return to their heart. And barotrauma, this is a change in pressure, so increased pressure at the end of the alveoli. It can cause air trapping. It can cause increased risk for pneumothorax, and they might have to put a chest tube in prophylactically, or certainly if they develop a pneumothorax, they would put one in after. And then the volume trauma is just when they have too much tidal volume in their lungs and they're hypoventilated. Okay, so alveolar hypo or hyperventilation. So this is either there's not enough ventilation getting to the alveoli, so not enough keeping them open, not enough room for gas exchange, or if they're hyperventilated, they have too much going in. And you can see this with patients who have COPD, if you're giving them too much air, so their bodies are set. If they're CO2 retainers, this isn't just your gold one COPD, but somebody who is a COPD I'm sorry, a CO2 retainer, they're they have that body's used to having that extra acid in it, so the kidneys produce more base. They kind of manage that on their own. They get in that baseline thing. So if we bring them in and we put them on ventilation, we have to be careful with hyperventilating them because we can cause alkalosis because their kidneys are producing more base than a normal person. Neurologically, so just like you're having decreased venous return, you can have you're going to have decreased return from you're going to have increased ICP from decreased return through the jugular because with that pressure in the thorax area. So keep the head of the bed elevated. You keep the head in alignment to mitigate that pressure. Um, yeah, the GI system really takes a hit. So you're under a lot of your body's under a lot of physical stress. So you are quickly develop ulcers in your GI system. So we're going to give you prophylactin H2 receptor blocker, a PPI. I think it's usually a PPI, Protonix, and the enteral nutrition to keep the acid down in your stomach. You could also have bowel dilation. So if that was the case, then you would have to decompress your stomach. So they put the NG tube in to suction to decompress the stomach. And then, of course, decrease peristalsis leading to constipation. So you want to make sure they have a bowel regimen. And you can imagine that you're laying in bed for a while, you're definitely losing muscle strength, and you have all the problems linked with that with immobility. So you want to, make sure you're doing range of motion and get physical therapy and occupational therapy involved early so that we can try to prevent the loss of muscle strength. Okay, ventilator associated pneumonia. This is a really big problem for people. Again, you have all of that bacteria in your mouth and we're going right into your lungs. So you're at really increased risk of getting pneumonia. So make sure nurses have to be washing their hands. There's also environmental factors, colonization of the oropharynx, bacteria all lead to pneumonia. And things we can do to prevent pneumonia in the patient who is on mechanical ventilation is trying to minimize sedation, but that's a balance, right? Because you also have to keep their anxiety down. Early exercise and mobilization. In some places, they're waking them up early. If the patient can remain calm, they're like, even sitting them up in the bed, keeping the head of the bed elevated, and oral care every 2 hours. And that is it. All right. Well, thank you so much. Send me an email if you have any questions.